So, hello and good evening to everyone who have joined for this session. So, once again, we're going to speak something about toxicology this time, and we are also going to speak something about a recent update by the American Heart Association. So, without further ado, we'll start with the case scenario. So, basically, we have a young 27-year-old patient coming with nausea, vomiting, diarrhea a few hours after ingestion of around 30 tablets of lithium, which is the immediate release version of lithium. And the patient was recently started on lithium tablets a few days back, and the patient was not on lithium prior to this. So uh, today we are basically going to be speaking about lithium and the different manifestations of lithium toxicity. So if you read about the history of lithium, it's actually quite fascinating, history of lithium in medicine. So it goes back to the 1800s, and it was initially used for something like gout. Later, it was used for syphilis. For some time in the 20th century, people thought it would be good to actually use it for heart failure, and all of those ideas failed. And eventually, it made its way into psychiatry. But even after all of these years, more than 200 years, we are still uh, not sure exactly how it works. It is primarily thought to be acting through modification of messengers, intracellular messengers, and through that, it is postulated that affect the functioning of dopamine, serotonin, norepinephrine, etc., and lead to mood stabilization. So lithium is a monovalent cation. It will compete with other cations like sodium, potassium, magnesium, calcium, etc., and it will interfere with sodium ions through interaction with sodium channels and sodium potassium ATPase pump. So, and it will also lead to nephrogenic diabetes insipidus as well. So one thing that you should keep in mind that is of practical importance is that medication that can increase sodium reabsorption in the kidney can lead to lithium toxicity, or literally anything that can force the body to start retaining more salt in the body will lead to lithium toxicity. And similarly, any medication that can lead to excretion of more sodium from the kidney can also theoretically increase the excretion of lithium through the body. So these are the uses that I'm sure most people are familiar with. So BPD and acute mania. So one thing that is important here is that lithium is one of the few drugs that have been shown to reduce the incidence of suicide. So even if a patient who is on lithium develops lithium toxicity, once the patient starts recovering from toxicity, the psychiatry team might want to actually restart the patient on lithium, which is kind of unusual, but it might be indicated. So coming to pharmacokinetics, the oral absorption is very good, and the absorption for immediate release tablets is within a couple of hours. The delayed sustained release tablets might get absorbed a little slower, like up to 6 hours or so. And it is not really that much protein bound. And whenever you hear this thing, then one thing that should immediately come to your mind is that this drug will be amenable for dialysis in toxicity. So another thing that you have to remember is that serum concentration is actually not a very good marker of exposure and a poor predictor of severity or prognosis. So why this is the case is because what's it called, a single serum value may not be that reliable, especially if it is a sustained release tablet. That is one thing. Second thing is that the severity of the overdose and the prognosis will mainly depend on the amount of lithium that actually gets into the brain of the patient, and that the absorption into the brain is actually delayed, and it might take actually 24 hours for that to occur. So serum levels, in the blood, that is not a very good marker about the severe. And it is recommended that you actually repeat level every 2 hours until until the levels actually peak. So which may or may not be possible in yourself. So this we already mentioned, and the distribution of lithium into the brain is relatively slow. So it may take up to 24 hours for the CNS manifestations. So the half-life is around 18 to 24 hours in the young, and it will be more almost double in the elderly patients, and even more on patients who are on the prolonged therapy. And it is reabsorbed to through the proximal convoluted tubule. There is no metabolism of lithium, and it is excreted in urine. And the why this is an important drug to be aware about it is because it has a narrow therapeutic. There are some adverse effects that will be present even with normal doses of lithium that we should be aware of, like fine tremors. So fine tremors can be occurring even if the patient is on prescribed doses of lithium. Whereas if you are beginning to have coarse tremors, then that is a sign of toxicity. So fatigue, polyuria, and nephrogenic DI, so that can also occur even with normal doses. It can interfere with the thyroid, leading to hypothyroidism, and it can also cause hyperparathyroidism. So in patients presented with lithium toxicity, it is important to measure the thyroid function test, and also be aware and look for hypercalcemia, because that may also occur. There are some risk factors for toxicity, and the important ones are if the patient is having is given some other medication like NSAIDs, ACE inhibitors, any kind of fluid loss from the body. So most commonly is going to be some gastroenteritis like vomiting, diarrhea, and especially in elderly patients, or if the patient is started on diuretics for heart failure or something. These things can increase the risk of lithium toxicity in patients who are already on lithium. So the toxic effects of lithium, this is the basic crux of this lecture. So if the patient is coming with acute intoxication of lithium and patient is not really having much prior exposure to lithium, it will present mainly with the gastrointestinal symptoms. Whereas in a chronic toxicity of lithium, it will present with more CNS symptoms. Acute on chronic toxicity will have a mixture of both. So in acute toxicity, the main problem is that it is a vicious cycle. So it will there are GI symptoms, nausea, vomiting, diarrhea. This will basically lead to volume depletion and a pre-renal AKI, and this will eventually lead to a decreased renal clearance of lithium, and this will again contribute to more lithium being retained in the body and eventually leading to more and more toxicity. So that is a big problem with acute toxicity. The CNS symptoms are generally a little bit more delayed, and patients can develop cardiovascular abnormalities like hypertension, bradycardia, AV blocks, dyslipidemias, etc. Rarely, patients can lead on to ARDS as well. Chronic toxicity is basically going to be CNS symptoms. We'll have the coarse tremors. We'll have lots of cerebellar symptoms like ataxia, dysarthria, nystagmus, etc. You can have some clonus, some weird movements, attitude movements. In very severe cases, it will lead to seizures, altered coma, etc. Rare manifestations include hypo and hyperthermia, peripheral neuropathy, and severe leukopenia. We have to remember that if the patient is having hypothermia with lithium toxicity, you'll have to start controlling the temperature because it can lead to more adverse effects in the brain. So acute and chronic, basically, it will be precipitated by some of the risk factors that I mentioned earlier, and basically, it will lead to the disruption in the normal balance of the lithium in the body. And again, the most biggest problem here is going to happen if the brain levels of lithium is going to increase. So there is something called silent, that is syndrome of irreversible lithium effectuated neurotoxicity. So what does this basically mean? This is a recently recognized syndrome, a little bit controversial also. So basically, it is a persistent neurological dysfunction more than 2 months after you actually stop the drug in patient without any prior illness. So it can present with things like ataxia, tremor, scanning speech, gait imbalance, etc. So this is actually very bad. Basically, it is thought to happen in chronic patients on lithium chronically, and they develop toxicity, and you end up treating them for toxicity. So if they are completely removed from all of the lithium is completely removed from the body, then this may occur. The how it actually occurs is still controversial, not very well understood. But this is one of the reasons why, considering why dialysis in lithium is a little bit of a double-edged sword. So this is one of the things that you will be afraid of when taking care of a patient with severe lithium toxicity, especially if they were on chronic lithium. Coming to the grading of toxicity, it can be mild, moderate, or severe. Mild, you'll have some GI symptoms, some fine tremors, which can be present even with the normal doses of lithium. With moderate toxicity, you'll get more of the CNS symptom, confusion, agitation. You can have increased tone and increased reflexes, as well as some of your cerebral symptoms that I mentioned. Severe toxicity, you'll get seizures, coma, hyperthermia, and arrhythmias as well can also occur. Coming to the diagnosis is basically clinical. When you are measuring blood lithium levels, make sure to use vacutations which are free of lithium. Otherwise, the values will not be reliable. Normal levels are thought to be 0.6 to 1.2 millicoulombs per liter, and toxic dose effects are generally thought to happen at more than 2 millicoulombs per liter. But we have to remember that it's generally going to vary depending on whether the patient was on lithium chronically beforehand. Because if the patient was on lithium beforehand, then it doesn't take a long time for the lithium levels in the brain to actually start. So the toxic levels will actually start occurring at a lower value than this. So other labs that I mentioned, you have to go for a CBC, RFT, and thyroid function test. So basic evaluation of lithium toxicity when you're taking the history, that is something that you have to ask for. One is obviously the amount of lithium ingested, the number of tablets, etc. Generally, the toxic dose is thought to be around 40 milligram per kilogram or around 3 grams, but that is a bit dicey. It's not a hard and fast rule or anything, but general the number, if you're asking, it's around 3 grams. Then you have to consider whether it is immediate release tablet or sustained release tablet, because it will have some implications for management. Then you always have any kind of toxicological ingestion. You have to look for any possible co-ingestions as well. And importantly, you have to look for patients any proof for volume status. So if the patient is having history of vomiting, diarrhea, etc., then the patient is likely to be volume depleted. If the patient was having some heart failure prior to presentation, patient is having some renal dysfunction prior to presentation, maybe the patient is going to be a little bit more on the fluid overloaded side. And obviously, you'll be using focus to actually assess this in detail. And also, you have to evaluate for any recent medication changes, whether something like NSAIDs were added, some diuretics were added recently that might have precipitated the lithium toxicity. Coming to labs, in the CBC, chronic lithium use can lead to a leukocytosis. So that is something that you might see, and that doesn't really mean that the patient is having an infection. Venous blood gas, you can actually have a reduced anion gas because lithium is a monovalent cation. Obviously, you're going to look at your RFT, GFT, etc. Look for calcium because lithium chronically can lead to hyperparathyroidism, and you go for a lithium levels as well. And in physical examination, you look for the features of toxicity, and focus, you look for volume status of the patient as well as your cardiac function. So what are the things that you look for in the physical exam of lithium toxicity? Look for things like nystagmus, whether the patient is able to talk, whether the patient is altered, patient having dysarthria. Look for any kind of tremors, and you also assess for power and reflexes, whether there is any hyperreflex. ECG changes. So basically, there is no specific ECG finding that is going to point towards lithium toxicity, but there are some things that you have to be aware of. So it can lead to prolonged QTC. So you have to be careful while giving other things that prolong QTC in the management of this patient, especially things like ondansetron that might make things worse depending on how much the QTC is. So you can have some non-specific TBA flattening or inversion bradycardia, and you can also have a type 1 Brugada pattern as well. So this is an ECG of a patient with lithium toxicity, and the patient's lithium concentration was actually 4.3 in this patient. So you can see here, you can have, there is some sort of sinus node dysfunction leading to an irregular rhythm, and you can see a type 1 Brugada pattern in leads V1 and V2. So I'm not going into detail about the different types of Brugada pattern, but basically the type 1 Brugada pattern is basically an RSR dash pattern that is going into an ST elevation with terminating in an inverted T wave, which you can see here in V1. So an RSR dash pattern turning into an ST elevation and eventually terminating in an inverted T wave. That is the type 1 Brugada pattern. This can be obviously seen in many other conditions like Brugada syndrome and hyperkalemia, some myocardial ischemia as well. So it can be seen in multiple things, but it can also be suggestive of lithium toxicity. So this is something that you have to keep in. Management has, as with any toxicological problem, supportive care is extremely important. So initially, it's going to be all about your ABCDE approach, and you also remember to take an ECG as well. Coming to the specific toxicological management, GI decontamination, very little about this. So activated charcoal does not bind with lithium, so there is no point in giving activated charcoal to the patient. Gastric lavage is usually of the limited benefit because most, especially the immediately release tablets, they'll be absorbed very, very quickly, and it's unlikely that it's going to be having much benefit. If the patient took sustained release preparation of lithium, then you may consider whole bowel irrigation with PEG. But this is something that we are going to rarely consider. And again, with sustained release preparation of lithium, you have to be wary about pharmacological bezoar formation and intestinal obstruction that may occur as well. So in those cases, definitely PEG would not be indicated. But the basic thing that you like people to take away is that GI decontamination, not nurture. The most important part of management is going to be IV fluids, and IV fluids. So in our textbooks, Tindinelli, Rosen, etc., they will say initially start with a bolus of around 20 ml per kg. That is 1 liter of bolus. So if if it is a young patient coming with severe nausea, vomiting, diarrhea, 1 liter of fluids would be grossly under-resuscitating the patient. So the Internet Book of Critical Care generally says that you have to give lots and lots of fluid, like maybe even 4 to 6 liters of fluid. So that is going into the DKA territory of fluid management. So basically, lots of fluid. And then you give a very large rate of maintenance fluids as well. So 1.5 to 2 times the normal maintenance fluid. So around maybe 150 to 200 ml per hour of single lactate. And generally, you will go for isotonic fluids. So coming to something more controversial is whether you should add diuretics along with your fluids, which might seem counterintuitive. But the thing is that lithium is mostly absorbed in the proximal tubule. Some of it's actually also absorbed in the loop of Henry and distal tubules also. So diuretics might help to increase the excretion of lithium. So things like acetazolamide might help in the excreting out more of lithium a little bit faster than it would be by just giving fluids. But there is not much data to actually support this. And the biggest problem is that, of course, diuretics, if you give them, patient might go into volume depletion, and that will actually make things a lot worse. So this is given in Internet Book of Critical Care. So basically, this might be considered in that consideration in the ICU, where you have very where you can have very close monitoring of the patient, one nursing, etc. In those cases, you can consider this in selective cases, in selective indications. But in emergency department, this is definitely not something that you should be ever considering. It is much more likely to make things worse. Coming to another controversial thing, that is the indication for hemodialysis. Rosens has actually given very specific indications, like if the patient is having severe symptoms, coma, seizures, arrhythmia, you go for dialysis. Patient is having acute kidney injury, unable to tolerate IV fluids for some reason. Maybe patient is having some prior renal failure or heart failure, etc. In that cases, you go for dialysis. And the lithium levels that they recommend for dialysis is in more than 4 in acute cases and more than 2.5 in chronic cases. Why is it less for chronic in chronic cases? Because all of the there is also already a good amount of lithium in the body, and it doesn't take much for the lithium in the brain to actually start increasing to toxic level. That is why the cutoff in chronic lithium toxicity is actually a lot less. But but this is only one source. So if you actually look at all of the sources of when to do dialysis in lithium, the toxicity, you will have completely different values. 4, 5, 6, everything is completely all over the place. So we have like 8 different sources here telling you 8 different things. So up to date, gold francs and extra, everybody saying different cutoffs. So basically, the thing that you should probably take out of this is that it should be shared decision making with other specialty as well. This is probably not something that one person should be deciding whether to go for dialysis or not, especially considering that you have the risk of silent as well. When should you consider admission at any levels more than 1.5? If the patient took sustained release tablets, and obviously in order to severe toxicity, patient is going to need admission. So if the patient is having a patient is asymptomatic after acute ingestion, you should monitor for at least 4 to 6 hours. And obviously in severe toxicity, they will need ICU level of care. So basically the take-home points here is that if the paper you have to understand that the acute presentation of chronic toxicity of lithium is going to have different clinical spectrum basically. GA decontamination has very little role in the management of overdoses, and aggressive IV fluids are the mainstay of treatment. And dialysis is going to be taken after consultation with other specialties. So that was basically about lithium toxicity. And so before we move on to the next topic, if anybody has any doubts about this, they can ask it now. Otherwise, we'll go into the next topic that we are going to discuss today. You can type it in the chat box, or you can say, unmute yourself and say. Otherwise, I'll just continue. Okay, so I think we'll continue.